Today's topic is identification of SAM. What is SAM? Is severe acute malnutrition, and we will look at some clinical scenario. This is a very important aspect. Every nutritionist and dietitian must learn how to identify SAM. So if I may just start, not able to change the slide, what's happening? Oh, okay. So let's look at the definition of severe acute malnutrition. How will you identify SAM and how will we define? So there are definition given on WHO and UNICEF site to differentiate SAM from MAM and average nutrition. And the most important criteria is your weight for length, weight for height, your Z-score. So below minus 3 SD of median is SAM. MUSC, that is mid upper arm circumference. This is a independent indicator or say differentiator between SAM and MAM. So less than 11.5 mm, that is measured on a Shakir's tape or any other unstretchable tape, you can identify SAM. Then presence of nutritional edema, that is bilateral pitting edema, we need to examine. We are in 21st century. Every nutritionist and dietitian must learn to do nutrition focused clinical examination, and that applies even to severe acute malnutrition. So severe acute malnutrition, when we are doing, and if you have less than MUSC less than 11.5 mm, you have minus 3 SD, Z-score. These are the tables given on WHO site. You can download it and you can correlate with what you get it on the measurement of growth chart. So that is with help of growth chart you can do. Then you can see the bilateral, both right and left side of the body, and pitting edema. It should leave an impression on the leg when you press with your thumb, and slowly it come up, but it takes seconds and minutes. So if it is a leaving an impression bilateral, it is clearly SAM with Z-score minus 3 SD with MUSC 11.5 and edema. So this is how you identify. Again, then you will do your nutrition care process assessment, A, B, C, D. I don't need to go into the detail. Anthropometric, biochemical, clinical and dietary assessment. And this is how we will be doing anthropometric assessment. Very important. Most of us fail to do correct assessment for children because we are not used to see hundreds and thousands of children. So weight of the child, there are techniques to be learned in taking the weight of the child. There are weighing scales to be calibrated, and the height also should be taken correctly at the eye level. You are maybe very tall and the child may be small. When he is standing on a stadiometer, you must come to his or her level of height and then take it. Head circumference, this is what I am talking about, the tape and the skin fold thickness. Also the BMI chart above 5 years, we have it, Dr. Khadilkar's and IAP merge one. You can use blue and pink one for boys and girls, and assess these criteria before you go into any management or before you label the diagnosis, nutrition diagnosis. So plot the chart, do these investigation, and then see at which criteria the child is falling into SAM or MAM. As I told you, the independent criteria, very easy on field and in hospital, is MUAC. Okay, So this is how you do anthropometric assessment. This, when you download these Z-score charts, you will see these how to determine nutritional status via Z-score. So there is more than +3 SD above normal, +2 normal height. I'm not going to go into the detail. Then the obese, overweight, and how you interpret these Z-score with your weight for age and weight and height for age and BMI. And this is like normal height is less than -1 or plus or minus -2, and then here it is -3 SD, severely stunted, severely underweight, severely wasted. So this is your SAM child. So then let's go to the MUSE. How do you do it? This is the second step. It has a green color, it has a yellow color, it has a red color. So when you put it on a mid-arm point, you will see if it is yellow, it is MAM, if it is green, it is average, and if it is coming in the red, then it is SAM criteria. So also you can see MUSE may be more appropriate than wait for high Z-score. This is what the WHO and UNICEF tells us. Also we can do, if it is 1 to 5 years, your arm fat analysis or a muscle analysis. These are little detailed one, but in the field and also in the hospital, it's very easy. This is how you go: one step, second step. You test the bone, your scapula bone, your elbow bone, take a midpoint. The hand should be straight, not folded. And then once you take the end point, midpoint, then you put your tape around. So it should not be very tight. See, the line of your arm should be straight. It should not go in like this. This is very tight, and this is your tape in a position for too loose. So it should not be too loose, it should not be too tight, and this is how more than 11.5 here is your SAM, yellow is your 11.5 to 12.5 is your MAM, and then the green one is more than 12.5. So this is how you will identify, you will interpret for SAM infants more than 6 months of age with other features also. We should never depend on only one. Yes, MUSE is perfect, independent detector of SAM or screening point, yet you will need for your more than 6 month age and less than 6 month age different criteria to tally whether you are going wrong or whether you are correct. So weight to height less than -3 SD for more than 6 months, visible severe wasting, mid-arm circumference less than 11.5, edema feet. If it is less than 6 months of age, the small children, then you will have to do, if they are less than 49 centimeter in length, following features should be there. That is, your weight for height should be your -3 SD, your visible severe wasting, and edema. It's easier said than done. So we really need to be develop expertise by doing these measurements in many children. So there are reliable screening tools which also can be used on the field and in the hospital. SDNA, the Pediatric Subjective Global Nutrition Assessment, the STAMP, that is screening tool for the assessment of malnutrition in pediatrics, and PMST, that is Pediatric Malnutrition Screening Tool. You can download these tool from the website and see whichever is suitable and appropriate for the age and for the condition. You can go ahead. So there are in-depth assessment, comprehensive assessment for SAM children, and simultaneously you have to take a history. So when you take the history and clinical examination, then you will be having the complete diagnosis or identification of the SAM. I'm not going to go into the detail. The history is your intake, recent intake of food and fluids, and we know that the SAM children will not have any intake because they will not have appetite. They will be just lying down in a same position for days together, and that's why this is not be there. So those other children where there is a little intake or little appetite, you can take these history points which I have mentioned here: breastfeeding done exclusively or not, depending on the age of the child, the type of diarrhea, the cough, the appetite loss, the contact tuberculosis in the family, or vaccination and other pediatric history, related history we take for every child. And then examination of your, as we have done anthropometry, then you must also do the other hands, nails, pallor sign, dehydration sign, very, very important. These children are dehydrated. Also, degree of dehydration should be evaluated. Then your eye, because the vitamin A deficiency is very, very common in these children. We all know that these are type 1 and type 2. So, type 2 nutrient deficiency is SAM. So, which are different nutrients which I not scope of this particular talk, so I have not included it, but it is already there. You can refer to it and then take it into consideration. So, vitamin A deficiency, you must look for it. Then localized signs of infection should be looked for it. Temperature, very important. You must know what is the minimum temperature on the thermometer, because these children will have minimum temperature 35, less than 35. They will have hypothermia. 3H, you must remember, as we go along, we will see the other mouth ulcers, skin changes. This is nutrition focused clinical examination I am talking. Desquamation, ulceration, and exudative lesions resembling severe burn, often with secondary infection including candida. Here we can see pitting edema. Here we can see pallor sign, severe wasting, and eye signs. Okay, just for images to be clear with what I have already told you. The grades are given here: absent, no bilateral pitting edema. Then if it is absent, then you can write. If it's mild in the feet, 1+, 2+, 3+. And dry conjunctiva for your conjunctiva bitter spot and vitamin A deficiency. And this is the typical your SAM child and the feet. So these are other clinical signs which you will do as a nutritionist in your clinical focus, nutrition focus clinical examination: angular stomatitis, skin changes, sparse and bleached hair. We have seen it, and the Harrison's sulcus. So when you see this, write down in your notes, and each one you will have to tackle in your management, which is to be tackled first and second. The WHO UNICEF has already put up how to go about with tackling. The first important, so there is a monitoring protocol with height scale, weight scale, MUSE, calipers and measuring tape. Frequency of measurement, how you do it. Initially you do daily weight, and you do there is no need of doing daily MUSE. You can do once in 15 days. So these tables are available on the WHO website. Then you will have the criteria are given for admission. Which child should be immediately rushed to nutrition rehab center? So there are some criteria which again I am not going to go into detail, but for SAM again same, once you identify and you know that the child requires hospital admission. Some noise at the background, kindly mute. Technical team. Yes. Then there is criteria for admission for inpatients. So you can refer pediatrician when they see the child, they will refer to NRC. The nutritionist when they see it in the community or in the ward, you can refer it to the SAM clinic or a pediatric clinic, and child can get admitted. And there are simple criteria given here. I am not going to go into the detail. So there are a complicated severe acute malnutrition protocol. We see phase 1, that is stabilization phase from day 1 to day 7. Then there is a rehab phase, which is week 2 to week 6. So what we see initially, we see hypoglycemia, hypothermia, and hypoxia. So as soon as the child comes to the hospital, is given oxygen because he is hypoxic. Okay. Then hypoglycemia, the glucose is given, and hypothermia, child is wrapped into the many blankets or under the light, and the heat is given to the child. And comes your dehydration, and you will treat the dehydration of the child when you see dehydration on the nutrition focused clinical examination with a pinch of skin, which we saw. So this is your principles of management. So you will treat or prevent hypoglycemia, first phase. Second, treat or prevent hypothermia. Then your treat and prevent dehydration, and oxygen is always given when the child is in, because child is unable to breathe. Then you will correct your, as a fourth step, correcting electrolyte imbalance here. Throughout this is done, not only in the stabilization phase, but even in the rehab phase also, correction of electrolyte balance. Then you will do fifth step, you will treat and prevent infection, very important. So the antibiotics will be started by the pediatrician. Sometimes pediatricians also are not having knowledge of treating SAM, because SAM identification is not done, and it is just taken as a failure to thrive, and they treat with a high or a fast infusion of electrolytes, and the child will have a fluid overload and succumb to it. So we have to be very, very careful that these children will have shutdown on the renal pump, that is your sodium potassium pump, and cannot manage very, very high heavy load of your electrolytes. So you have to be very, very careful. As a nutritionist also, you should know, and it's a teamwork. So you can always work together with the pediatrician, and if you know these criteria, you can coordinate, you can discuss and treat. So correct micronutrient deficiency is a sixth step. Sixth step is in A and B, then provide iron only later on. Initial phase, we are not providing iron, as we know child is infective and we need to correct other parameters. So providing iron is a sixth B step here, okay, in a rehab phase, not in a stabilization phase, because of the severe infection, and you are going to treat the child with antibiotics. And then start cautious feeding as a seventh step. As we go along, we will see this in detail, but this chart is very, very important. You can download it from the WHO UNICEF website and keep it in mind right from identification to the different phases of management. Then here 8th step is achieve catch-up growth. Then there is provide sensory stimulation and emotional support as a 9th step. And then you will prepare once child start taking, see both the step, this is there, both the phase, this is there, a sensory stimulation, tender loving care. You can touch with your hand over the child's body, all over the surface, carry him, put it near to your body, skin to skin touch, and that is very, very important to stimulate, and child will be getting emotional support plus sensory stimulation, and child's appetite will improve, child will start responding, and then you can start cautious feeding. So few busy slides. This is all there on our website. This is hypoglycemia. Many times on our rounds we have seen, then when I am finishing taking the round from the first child to the second child in an NRC center or in a pediatric ward, by the time I reach the 10th child, the first child has already gone into hypoglycemia and died. This is very common because they are going into hypoglycemia very frequent. Even while they are waiting in the OPD for their turn to come, they go into hypoglycemia and they die also. Also, there are, because of the hypoglycemia, there are so many changes in your brain and death of the tissues, brain tissues. So therefore, very important to give 10% of glucose or sucrose 2 hourly while they are waiting, either in the ward or in the OPD, or while even you are taking down, the nurses should manage giving them glucose. So blood glucose, when blood glucose is less than 3 milliequivalent or 3 mmol or 54 milligram, you will continuously give glucose. So this is very important feature, and after giving this, you need to do hydration, rehydration. So the rehydration therapy begins with the first feed of 75, F75 and F100 you must have had. But before that, we correct dehydration as per the degree of dehydration by giving oral rehydration solutions. I'm not going into detail of this. This is hypoglycemia with hypothermia and so this is what we do as a treatment for hypothermia, which I have already spoken, that we first of all give them enough warmth. Okay, once the temperature is below 35, you need to give them proper blanket and proper light, or if the child is very small, you can put it in that incubator like tray, or wherever the child is put, you can put the light and wrap them up. And then as a prevention, we will see that immediately here we are not going to start feeding, because these children are not going to accept your feeding unless they are stimulated in their response, skin to skin touch, and also your tender loving care with an emotional support. So very carefully we will go. Hypoxia I have already spoken about. We will give the oral rehydration. So here we will see what is the degree of dehydration, severe or some mild dehydration. There are criteria and the symptoms written here: lethargic, sunken eyes, not able to drink or drinking poorly, or skin pinch, goes back very slowly when you take a pinch. Okay, so if you have this, it is severe. And if you have restless, irritable, sunken eyes, it drinks eagerly, thirsty skin, and pinch goes back slowly, there is some dehydration. So first you determine the degree of dehydration, and then you start by this examination. So it is a nutritionist who does this investigation, because then you will have to decide what are you going to feed these children. So before you start rehydration for severe dehydration and mild dehydration, you will weigh the child, and as per the weight you will calculate, you will mark the edge of the liver, the costal margin, you will record the respiration rate. These are quickly done by the clinician and the nutritionist, and we start able to give ORS if the child is taking orally then. Otherwise, nasogastric tube is inserted and ORS is given. Remember, the commercially available ORS is not to be used for SAM children. If you want to use that, you need to dilute it to 1.5 liter. That sachet which we are generally dilating for diarrhea and dehydration in 1 liter should be diluted in 1.5 liter. To in short, the practical tips I am giving you. So that's how you will dilute it, because their kidneys are not functioning, their sodium potassium pump is shut down. So after giving the ORS, and if the child starts gaining weight, even if it is 5% or a 10 gram or a 5 gram, it's a good sign. And then you can start your different formula of F75, F100, or if the appetite test is done, we'll just see here the diagram here for rehydration, how it is done. This is all there. Conscious patient and unconscious patients, how we will do. Rhizomal is the name, but how you will have to dilute it. If it is unconscious, you will give it is with the 5% glucose for hypoglycemia, and you will give it very, very slow, 15 ml per kg, second hourly. So you will say, why should we know this? But if you are in a team, pediatric care team, there is something like pediatric care team where there is a clinician, there is a pediatrician, there will be DNB students, there will be MD pediatric students, and there will be a consultant, and there will be an intensivist, because these children will require intensive care admission. So, and the dietitian and pharmacist will be the team, sometimes psychologists, sometimes feeding psychologists. Abroad they have feeding psychologists also on the team. So your entire team decides. So everybody should be knowledgeable for this, and then you will start rehydration with monitoring weight. If weight gain is there is a clinical improvement, you will continue target weight, you will start F75. Then if it is not improved, then you will stop all rehydration and give only F75, because you do not know how much volume is given. So this will be 100 ml giving F75, okay. So that F75, F100 formulas commercially available. You can also prepare it in your NRC center. Then if your child is stable, then you will increase your rhizomal, that is 5 ml per kg per hour. Here it was 2 hours, here it is 1 hour, okay. And then you will assess every hour, and then if there is a loss, then again you will go back to 10 ml per kg per hour. So this should be done very, very carefully. You don't want your child to succumb to overhydration or fluid overload. So this is also again a busy slide, but it is for ORS. How do you give ORS? How often to give ORS? Every 30 minutes for 2 hours, which we have seen it in the other algorithm table, previous slides. And how you will make ORS also is here. Here it is 1700 ml they have diluted. So if you can also dilute to 1700 ml or 1500 ml, the packet which comes to be diluted in 1000 ml for these children. So the correction of electrolyte balance, as we saw in the phase, it is throughout, right from day 1 to the rehab phase. So this is very, very important. Once you achieve this, then you will go over to the other management. This is also a busy slide, but this is again simple algorithm, weight based and symptom based. The oxygen is given and IV is given, and then how you are measuring. Of course, the clinician will also be seeing it, but you will also see what is going. Assume the child has septic shock, then the child is in ICU and managed by the clinician. So IV fluid, there is a ringle acting, is generally used as an IV fluid with 5% of dextrose. So you can use 5% of dextrose. There is a weight based table given here, how much of volume as per weight, and how you will give it over 1 hour, 150 ml or 50 ml per kg. So that's how very detailed and correct calculation should be given. Do not give an initial bolus. There is no bolus to be given to SAM children. Always it will go as a continuous infusion. Remember that. Antibiotic, yes, antibiotic is the first line of management. Day 1, the antibiotic will start, because these children will have infection, which will be done by your clinician, cefoxamine, will be given 150 milligram per day, and they will be doing this as a medical management. Then there comes micronutrient supplementation, because I told you that severe acute malnutrition, moderate acute malnutrition is not the regular micronutrient which we see, it is the different type 2 nutrients. So we need to cover up these for less than 6 months. Vitamin A doses are given. If it is more weight, how much to be given? So weight based doses are given. These are detailed charts are given on the website. You cannot afford to make any mistakes, because every life is precious. So you will have to, and if the clinician is not aware, definitely pediatrician, when they do DNB and when they do MDs, they also do training for SAM management. Special training is there. There are regular workshops goes on, and the doctors and the nutritionists and the nurses, infection control nurses, attend this workshop. So this is how you will look into folic acid 5 milligram on day 1, then 1 milligram, elemental zinc 2 milligram per kg. Even if the pediatrician has prescribed, have a look at it, whether he has done it right or not. You can always intervene. It's a teamwork, and we don't want under nutrition in micronutrient supplementation or over. So you should know copper is 0.3 milligram per day, and iron is also given with 3 milligram per kg per day. So these are some essentials for feeding in the stabilization phase. After you are given your corrected hypoglycemia, hypothermia, hypoxia, dehydration, F75 you have given, and then you have moved up, you have corrected the electrolytes, then you will move up to the different phase. Okay, remember that small frequent feeds with low osmolarity and low lactose. They cannot tolerate lactose, plus they cannot tolerate high osmolarity of the feeds. So it should be very, very minimum osmolarity. Never give parenteral preparations. We are also scared to give IV antibiotics and IV fluids to these children, because they don't have better vessels. They are all diffused because of the dehydration and severe acute malnutrition. So you have to be very, very careful. So parenteral preparations are no for a severe acute malnutrition. Energy requirement 80 to 100 calories. It was earlier 80, now WHO has moved up to 100 calories. And this is how the frequency 2 hourly, 3 hourly with volume 11 ml, 16 ml, 22 ml is given. Then total 130 ml you can reach. Then 150 ml has to be reached. With severe edema, you will give 130 ml per kg per day of fluid. That is 100 ml per kg per day for edema. So one important counseling for a nutritionist is you must encourage breastfeeding continuously till the child is 2 years or even older. If the mother is feeding and mother is having milk, improve the nutritional status and allow both mother and child skin to skin contact, and even if there is no milk coming, the child should be put to the mother's breast. So initial phase we saw F75 130 ml per kg. These are commercially also available. As I told you, we can also prepare. So if the child given less than 80 calories per day, then protein catabolism and wasting. So never go low. On day 1, you must meet 80 calories at least. Nowadays, WHO is telling 100 calories per day is the better way of calculating and going ahead. So this is how you will go, and please avoid refeeding syndrome. And refeeding syndrome will be avoided only by not giving bolus and not giving the fast infusion to these children. So there is a appetite test table, because these children have zero appetite, and that's why they are not accepting anything by mouth. But you want to do the test and you want to give them feeding after rehydration. You want to give them high energy feed, that is your RUTF, ready to use tube feeding. Okay, this can be also given your orally also. So you must have this table, download. These are sachets commercially also available. Proactiva is there by company. There are micronutrient sachets available, which you can also add if you're preparing your own RUTF. You can tell the mother to prepare their own RUTF, because these are not readily available. Only city you will get your commercial preparations, and we see more community these children. And appetite test also, this sachet is used after determining the requirement of the child. So there is a lookup table here which you can download and see how much weight and how many feeds and how much of volume. So these are tables are available, and based on this table only you will decide how much RUTF to be given. You cannot give any amount. After the appetite test, how much RUTF to be given using by lookup table. Okay. So this ready to use therapeutic food, you can dilute it and give it. Even sometimes we use it in an NG tube, but otherwise it is like to lick it. Okay. So you can use it. This is the peanut paste, skim milk powder, powdered sugar, soybean oil, and micronutrient mix is added. A sachet in there, and emulsifier is added. This is how it is prepared, and 92 gram is the weight of the sachet or weight of the paste. And you can look up how much you will give for that weight, starting from day 1 to day 7, or how you want to, till the child gains the weight. You are going to use this because this is very dense energy, high energy RUTF. So there are some RUTF prepared by some NGOs, locally prepared, ready to use, because we cannot have everywhere from the NRC centers, or they cannot afford to buy the ready to use. So I've just put up the list. So the step up of feeds, the protocol should be used. If vomiting, then you reduce it. If poor appetite, then you go to hourly feed. Okay, and go slow for these children. Then there is a rehab phase, and in rehab phase you can increase your feed, increase your F75 to F100 in 48 hours if there is weight gain. If there is no weight gain, you are going to go back and look at the algorithm and start doing your rehydration, ORS, and the RUTF. Okay, and then if there is regain, then you F100 is given, then 150 to 220 calories are increased, and protein is also increased once the child gains weight. Okay, but initially it is 0.8 to 1 gram. Never go beyond 1 gram per kg body weight. The child will die of renal failure because kidneys are shrunken and the pump is shut down. It is not going to take the protein load. Okay, then comes your follow-up phase, and these are the recipes which you also can see on the website. I'm not going to spend time on that. This feeding for catch-up growth is there. As the child gains weight, during the rapid weight gain, you will increase the calorie, increase the protein, 100 calorie, then 2.9 gram protein per 100 ml, and you will initiate the dense feeding through tube or oral plus tube, NG tube also should be given. We are most probably avoiding sometimes NG tube because this child, they are anemic and they may bleed while inserting the tube. So there are here few danger signs where you have to look the pulse, your respirations, and the breaths, which of course the clinician will do it, but you must also see the notes, what is written. Just don't write the feed and go away. Read it very carefully. Above, if signs are there, then you are stopping all your feeds and ORAs and do complete evaluation and go back to your 0 level. So there are some criteria where there is the failure to respond. So those children who do not respond by, with After appetite, regaining appetite by day 4, failure to start to or to edema does not start subsiding by day 4, then you will change the protocol. Okay, your weight is your marker. 10 gram weight. If child starts gaining 10 gram weight day or in 2 days, then you increase your calories, increase your protein, increase your number of feeds, increase your volume. But if child does not start gaining weight, okay, and there is a weight loss, then you go back to what you have started. Okay, so that is very, very important how you do it. Then there are discharge criteria which are given when there is weight gain, okay, for more than 6 months, and for all some cured children, the follow-up is 3 months, okay, and MUSC should be maintained at MAM, because many times from 12.5 they go back to less than 11.5. Some MAM child becomes SAM again. When follow-up we see MAM child coming back as SAM. So that's why these criteria is important and you need to go into these. Just quickly to go over to a case, 1-year-old child, how will you do it? So the case study format is there on the website of IGA and RD board. Okay, the 6 kg weight, 11.7 kg, 63 centimeter, 13.9 BMI and 10.2. This is the BMI we're using the app, the IAP app. So you will plot the growth chart, the girl child, okay, and then you will see this particular child had a GDD, that is Global Development Disorder also, along with the SAM. Okay, it's not only SAM. Okay, mother's age and other, this history is very, very important. What was the mother's age at the child's birth? What was the child's birth weight? What are the family member? Whether there are any sibling, the first child or family tree need to be drawn. Immunization history is more important. Biochemical parameter to be interpreted. Here is the AST is high, ALP is high, the protein is low and CRP is high. So these are the medication on child is on antibiotics. There is vancomycin given, there is fever medication given, vomiting medication given, and child the vitamin D and vitamin A as per the phase it's given. The temperature is 37. So interpret this. How will you interpret? Elevated liver enzymes along with CRP elevation indicate inflammatory condition in the patient and often seen present with SAM children. Okay. Then low total protein, that is associated with excessive muscle wasting in the child, that is correlated to inadequate nutritional intake because child has not eaten for days together because of the appetite and the even global development disorder. So here you will do nutritional screening using SDNA or whatever MUST also can be used. Any tool can be used and put the score. So SGA score here, C, again the second page of that you will do the physical examination, GI function and functional capacity, the subacute fat loss and other questions if you are using HGA. This is the table which you will use for your physical clinical examination, nutrition focus, and relate it with these parameters. I'm not going to go into detail. As a nutrition dietitian, everybody should know this table is there, second page of SDA, and this is your clinical examination. Okay, so here you have your C for this chart. Now assessment is done, breastfeeding is done only 10 minutes, maybe the mother is also malnourished, only 70 ml, and then total energy consumption is 378. So on demand regular intervals, this child was breastfed for 1 year. Okay, and complementary feed was started from 6 months. So that's a good interpretation or history. So how will you interpret the recall? The diet is hypocaloric, okay, not enough. The child is consuming 37% of the RDA or EAR. calorie from protein is only 9%, carbohydrate is 46%, calculated fat is 45%, rich source of high biological value protein are absent from the diet, and breast milk is not enough. So diagnosis, PS system, you put problem, inadequate nutrient intake related to SAM, low appetite, or because of the global development in this particular case also. Both GDD and SAM is there in this case. Also, there is allergic proctolitis evidenced by symptom for this case. So there are too many things in this case. Allergic proctolitis is nothing but cow's milk protein allergy, which has gone undetected because the mother has started cow's milk at 6 months. Okay, so you will put down your goals, short-term and long-term goals, alleviating symptoms, like how you do it. Sometimes it is not possible for SAM children. So as per the SAM protocol, we will see, and you will follow the SAM protocol with F75, F100, or with a rehydration solution, Desomal, or you prepare it or advise. Nutrition education is must. Counsel the parent how to prepare RUTF, how to prepare ORS for SAM children, and then tell them how to give, and then you will interpret with RUTF lookup table using the chart. Okay, so 200 gram came for this child to be given for per day. So we don't know whether it will be taken or not, but that is the calculation. So you can start giving that. I would personally give ORS rehydration, then start F75, F100, and then incorporate RUTF, and then incorporate anything else like ragi or oat milk, because I'm not sure whether it is going to be table. But this is RUTF prepared for cow's milk allergy patient without milk, using the oat milk. So you have to prepare your own, or tell the child mother to prepare for cow's milk protein allergy. This is another subject we'll sometimes see in detail. So write your menu, like starting with 50 gram for your breakfast, and how you are dividing 200 gram. So 4 times in a day your RUTF, then as many times as possible breast milk. That is what I will advise. Okay, and if child is ready to take anything else, like any mashed banana or anything, then you can incorporate for energy. Thank you very much.